Hello, I'm Dr. Dennis Hartlieb, and welcome to another installment for the AACD Virtual Campus. The course that I'm going to be sharing with you today is what I call CPR for the Worn Dentition. What is CPR for the Worn Dentition, you might be wondering? Let me explain. CPR for the Worn Dentition is my process for working with patients who have severe tooth wear. Patients like Sam. And we have so many other patients that we see in our daily practices with severe tooth wear. But my definition of CPR is a little different than what you might be thinking. You look at these teeth, and they certainly need resuscitation. But for me, CPR is a mnemonic that represents my process of working through these challenging worn dentition cases in a predictable manner. Too often, dentists use a technique when they're working on these complex cases that I've heard described as prep and pray. They're not sure where they're going to be going with the case, but today I want to share with you a technique, a systematic approach when working with these complex cases so that you have success and predictability. So for me, CPR stands for from concept to prototype to restoration. So in Sam's case, and we'll go through Sam's case step by step, you see the preoperative photograph with his lower worn dentition, severely worn. And I show you the concept. The concept in Sam's case is this diagnostic wax-up. From that diagnostic wax-up, we go to the prototypes, and I'll explain the prototypes in detail. From the prototypes, we test those prototypes, and that leads us to the definitive restoration. Now, many of you are already familiar with the term transitional bonding, but I'd like you to think of prototypes as a different way to think about this transitional bonding. I'll explain how I think of prototypes a little bit differently in just a bit. But before we get into all that, I'd like to explore first, where is all this wear coming from? I mean, if you're like me, it seems epidemic. I'm seeing patients daily, it seems, that have wear on their teeth. It may be uppers, it may be lowers, or it may be a combination. In his excellent paper, Dental Erosion, Etiology, Diagnosis, and Prevention, Dr. Wren explained the effects of acids on teeth and where these acids originate. In his paper, Dr. Wren taught us that dental erosion is caused by sustained direct contact between tooth surfaces and acidic substances. And the demineralization of dental enamel will occur once the oral environmental pH reaches the critical threshold of 5.5. In his paper, Dr. Wren continues that the acids in the mouth originate from three main sources. One, in situ by acidogenic bacteria. Second is from ingested extrinsic acids, such as dietary acids, such as soda, coffee, other things like that. And the third is from intrinsic acids through, say, gastric acid backflow. We understand that the acids from bacteria are what cause tooth decay. But acids ingested, soda, coffee, etc., and acids from gastric and esophageal reflux are related to the erosion seen in many of our patients. And Lucy, in his monograph in Oral Science, Erosive Tooth Wear, a multifactorial condition of growing concern and increasing knowledge, he writes, erosive tooth wear is becoming increasingly significant in the long-term health of the dentition and the overall well-being of those who suffer its effects. Following the decline in tooth loss in the 20th century, he continues, the increasing longevity of teeth in the 21st century will render the clinically deleterious effect of wear more demanding upon the preventative and restorative skills of the dental professional. I mean, boy, isn't that the truth? I believe that we are all seeing more and more patients with these severe wear and erosion cases coming in our daily practice. So the question that comes to mind is, what do we do with such massive tooth structure loss?